Yeah, I know. Here's Stacy. Oh, this is our insurance expert from the unknown wilds of the state of Georgia, Stacy. Gee, if I'd have known it was you, I'd have gone to the phone sooner. I'm sorry.
No, that's okay, Rush. How you doing?
Well, I'm fine. How are you doing?
What a day. Well, listen, there's so much to talk about. And when I read the New York Times article this morning, I just knew I had to call you because there's so many problems with it. But the most important
with the
thing
story,
to tell
your problems with the story.
Oh yeah.
Yeah, it's not complete at all.
But the most important thing to tell you, is that there is a much more dramatic issue here for the 2014s than premiums.
What?
Let me explain it to you.
All right.
You go to your doctor, and your doctor writes you a prescription for an antibiotic. You go to the pharmacy. Now, there's 3 entities involved in that transaction at the
What
pharmacy.
if I have built up an immunity to the antibiotic?
There's the pharmacy itself. There's what's called a pharmacy benefits manager.
Oh, geez.
And then there's the insurance company, okay?
Mm-hmm.
Now, realize that Obamacare doesn't apply to the pharmacy benefits manager. Okay, they can do whatever they want to do in terms of communications, in terms of all this stuff. It doesn't apply to them.
Stacy, this is my bad. I didn't put 2 and 2 together and recognize that it was you, and I'm up against it on time. Can you hold on?
Sure.
Do you have some time for the next half hour?
I do.
Great. Good. Folks, if you've not heard Stacy before, she knows it upside down, inside out, and extremely adept at explaining something very complex in an understandable way. So don't go away. We'll take a brief time out. Be back after this. Okay, let's boil this down as we get ready to talk to Stacy in the next segment. Obamacare is mandating very low caps on deductibles and no limit on how much insurance companies have to pay out over a lifetime. And those companies are going to have to make up that money somewhere. And it's going to happen by raising everybody's premiums. And raising premiums on everybody, i.e. voters, is what Obama has now delayed until 2015. We'll be back. Hi, everybody. Rush Limbaugh, America's real anchorman, America's truth detector, and the doctor of democracy, all combined here is one harmless, lovable, adorable fuzzball. Executing assigned host duties flawlessly, 0 mistakes. Here at the Limbaugh Institute, telephone number is 800-282-2882. The email address, lrushmore@eibnet.com. An extensive discussion of the latest chicanery involving Obamacare being delayed in order to not harm Democrats. The 2014 midterm elections, and we now go back to Stacy from the wilds of Georgia. She's a regular, semi-regular caller to the program when she gets the itch. She's an expert in the health insurance field in this country and has the unique ability to take all this complicated stuff and synthesize it down and make it somewhat understandable. So let's pick up where you left off. We're talking about the rising premiums, talking about the lower caps, but you say that there's something in this that involving pharmaceuticals, prescriptions, and so forth. Why don't you pick up there at that point where we left off?
Sure, Rush. And I want everyone to understand this is way more complicated than I'm making it sound, but I'm trying to explain it in a way that everybody will understand the impact to every single person who walks into a pharmacy or walks into a prosthetic store, who walks into any place that you're going to purchase a product that is supposed to be covered by your health insurance.
Okay.
Okay? And the New York Times article claims that, that the insurance company's computers can't handle this. Well, I'm here to tell you that's a load of bull. We can do it. It's a database change. It's no big deal. Here's the problem. There's not real-time connectivity between all the pharmacies in your town, all the mental health providers in your town, all the prosthetic providers in your town. Okay, they don't communicate real-time with your insurance company. But we're supposed to be able to, in real time, tell these people how much you have to pay to buy your prescription or to see your shrink or whatever it is you're doing. So in particular,
that's for those who see a shrink.
Exactly.
Yes.
Well, and the pharmacy is the one pretty much everybody's done. You've been to your doctor for an antibiotic or whatever. You go to your pharmacy to buy your prescription. Now, what happens in the background that you don't see? There's 3 entities involved. There's your pharmacy, your pharmacist, you're standing there at the counter. There's what's called a pharmacy benefits manager. You can think of them like AT&T or Verizon. They're the people who are connecting the information from your insurance company to the pharmacy. Okay? Here's the problem. They don't connect real time with the insurance company. Usually it's a batch process that happens overnight. So when you go to your pharmacy and you present your prescription for amoxicillin, your pharmacist enters the information into a computer and you see that happen. What you don't know is that computer is going to the pharmacy benefits manager.
Where is this person?
Let's just say CVS. Pick any pharmacy. It doesn't matter.
But is he on site? Is he in the pharmacy?
Yes. You're standing there at the counter waiting for this pharmacist to give you your medicine so you can go home and take it because you're sick. You don't care what happens. You just want to go home.
I understand. I'm just trying to get a physical layout of where the pharmacist benefits manager's actually at his computer.
They can be anywhere. They can be in 3 states away. They can be in India. It doesn't matter where they are.
They'll be in Mumbai. Okay, I just wanted to establish.
Yes, doesn't matter. Okay. What they're doing is they have the connectivity to your pharmacist. And what happens is your pharmacist says, okay, pharmacy benefits manager, is this drug covered? What tier is it covered? How much does this person standing at my counter have to pay me to get this medicine? Okay? That's how it works today. Under what is they're trying to do in Obamacare, and here's what happens when you have bureaucrats and politicians who have no idea how anything works try to mandate something like this. At this point, the insurance company is processing claims. You've been to your doctor. You paid a copayment, right? So your doctor submits a claim. We're processing that claim. We're updating, okay, you had $1,000 and we're adding $30 to your out-of-pocket. Well, you're staying there at the pharmacist, and your pharmacist has no idea how much you have to pay legally to get that medicine.
Well, but he charges you something because everybody gets out of there with their medicine.
Well, but here's the problem. Okay, now you've got Obamacare that says that you can't charge over this amount. If the pharmacist takes your money, and legally he wasn't supposed to, he can get sued. If your pharmacy benefits manager tells the pharmacist to take your money, they can get sued.
But Stacy, how can they even set a price if they're not connected in real time? This pharmacist manager, benefits manager, he can't possibly.
Sure he can, because they're not connected to your health part. It's a different, you can think of it as a bucket. Think of it as a bank account, okay? The pharmacy bit is coming out of its own bank account. And then on the back end, the pharmacy benefit manager tells us, okay, Enos spent $100, worth of heart medicine at our pharmacy today. Okay?
Right.
We update our database with that. No big deal, because it's not critical today to know that. But when all this Obamacare crap goes in, then it's critical to know real time, and that's the key. Real time data exchange.
Why? What's changing? What about Obamacare is making real time relevant?
Because if let's say you're almost at your out-of-pocket max, okay? Say you got $20 till you're there. And you've been to your doctor, you paid a $20 copayment, you go to your pharmacist to get your medicine. Okay, by the law, you don't have to pay a dime for that medicine. But the pharmacy benefit manager doesn't know that. So the pharmacist doesn't know that. So they're going to say, okay, you owe me $20 because that's what it was last night.
Okay, so then what happened? You pay the $20 that you don't owe.
Right.
Do you ever find out you didn't owe it?
Well, I'm sure you will at some point.
How?
We don't know yet. Is it a report that's coming out the back end of us? Is it a report coming out of the PBM? We don't know. Here's the problem.
You mean to tell me that if a consumer is charged $20 he doesn't have to pay, somebody in a week or two is going to get a hold of him and say, by the way, we owe you $20?
Sure, or you can credit it to you. That's the problem, Rush, is figuring out the money end of all of this. The money end is very complicated. And now, not only is it just that we don't want our patients to have to pay extra money, now it's a legal risk. Now it's, you take your $20 at the pharmacy, and then the patient can sue the pharmacy or the PBM or the insurance company. Now, who's going to want to do that?
Yeah, I see.
Who's going to want to hand you that over the counter in 20 minutes at CVS?
Right.
So here's what's going to happen.
Well, that might,
they implement this stuff before 2014. And you've got pharmacies who can't do the connectivity. The PBMs aren't ready yet. Remember, they're not covered under Obamacare. They're not legislated to communicate in real time.
Never?
Never. They don't have to. They don't do it today. They don't care. It's not their problem.
But ultimately it is, because it's money. And when money's involved...
Ultimately it is, but legally, their legal risk isn't as great as the insurance companies or the pharmacists.
But, Stacy...
Think about it. They're Ma Bell. They're plugging it in.
Stacy, you know as well as I do that your industry is in the crosshairs now.
I know.
All of this is designed to practically make it impossible for you all to function.
I know, but here's the problem for 2014. When Enos goes into a diabetic coma standing at the CVS counter because Enos can't get his insulin because the connectivity doesn't exist to tell him how much he owes, what's that going to do to the elections?
But all that's been delayed, hasn't it?
Well, it has now, and that's why. Because people like me who work in this, who know, are going, you're going to have mass chaos.
But how is this any different under Obamacare? Because there were caps before Obamacare.
Oh,
and you could still be about to go over your cap now. It doesn't matter whether it's now or 2050. You could still be about to go over your cap.
Well, sure, but the difference is...
I just don't see how Obamacare changes this.
Because now it's one bank account instead of two. Remember before I said you think about your pharmacy stuff's coming out of one bank account and your doctor and hospital stuff's coming out of a separate bank account?
Yeah.
Now it's one bank account.
And it's yours.
And your money's coming in and out from all over the place.
But
right?
it's the insurance company's account, that's what you're saying here?
I'm using that as an example to try to visualize why.
No, but I'm trying to understand the perspective. You're in the insurance business. You're describing problems for you.
For me and for everybody who needs medical care. I mean, this is going to impact everybody at the point of sale when you're standing there at that pharmacy counter with the flu waiting for your Tamiflu. I'll tell you something else they've done, Rush, that nobody's talking about.
I don't see how Obamacare changes any of this. It seems to me that what's in the New York Times and Forbes today about these caps and delaying these massive premium increases, now that I can see.
Yes, but that's the easy part. That's the stuff that everybody gets. This stuff that I'm talking about is the day-to-day impact to you standing there at your pharmacist or standing there at your, waiting for your wheelchair, whatever it is you're doing. And the fact that we, insurance company, cannot communicate real time with the pharmacist, with the prosthetic guy, with whomever it is.
So basically, this is a legal liability concern that you've got here?
Well, it's legal liability. It's financial liability. I mean, $20 doesn't sound like a lot, but multiply $20 by, a couple of million subscribers. Then you've got a financial disaster on the back end trying to figure out where all this money needs to go. Remember, our goal is to never pay out more or less than we're supposed to.
You're speaking when you say our, the insurance company.
Correct. I mean, we want to pay what we're contractually obligated to pay.
No, you don't. Let's be honest. You don't want to pay. You don't want to ever pay.
No, we don't. You know, it's funny, Rush, talking about the lifetime max. Now, this is a totally different topic. The lifetime maximum in my company, the standard is $2 million. That was increased from $1 million about 15 years ago when an employee of the insurance company's wife came down with the necrotizing fasciitis, the flesh-eating bacteria.
Yeah, I read about that.
She came down with it, and within 6 months, she had already had like $1.5 million in claims to save her life. So the insurance company looked at these rare cases and said, okay, when you have this kind of infectious disease, your claims exposure is going to be greater. So they bumped it up all by themselves to $2 million. But the problem with that is, and it's not so much a problem with $2 million as it is with unlimited. You as a subscriber or your employer, whoever it is that's paying those premiums, are never going to pay that much money. In your whole entire lifetime, you will never pay that much money to the insurance company for your premium.
Because you're not going to be in business long enough.
I don't care. You could, whoever you are never going to pay that kind of money.
That's true.
So basically,
that's true.
Obama just made us welfare distributors. That's what we do now.
Okay, there you have it.
We don't do math anymore.
Strip it all away. That's what you're doing. It's just like the old general manager, the CEO of GM. So, I thought I got in the business to sell cars, and I'm a healthcare manager.
It's insane. There's so many ways that you can fix this, and this definitely is not it.
I'm not trying.
But guys, guess what? Now it's not just your antibiotics or your insulin or your heart medicine. Obamacare also has made it so that if your doctor prescribes daily aspirin for you, we now have to pay that.
Wait a minute.
No cost.
Who prescribes aspirin?
Doctors. This is considered a standard treatment for heart problems.
Oh.
It's a blood thinner. It's a low-dose blood thinner.
Yeah, but you can...
and now we have to pay for that. You don't have to pay a dime for it. If your doctor writes you a prescription, we have to pay for that. We have to pay for breast pumps. We have to pay for all this stuff that used to be paid by you. If you wanted it, you go get it. Great, but leave us out of it?
Yeah.
Now we have to pay in total for it.
Okay, I've got dwindling time here, and I'm still confused. I don't understand why one bank account or two bank account in your explanation.
Okay,
I don't know what's different now.
Okay.
As opposed to what's going to happen.
Let me
where
help
this
you with
pharmacy benefits manager guy, whoever the hell he is in Mumbai.
Okay. He's got his information that we link up nightly, okay? And we say Enos has met $1,000 of their out-of-pocket, okay? And we tell them that nightly, and then they send us a file that says, well, Enos went and got a $50 prescription, so add $50 to your bucket, and then the pharmacy benefit manager adds $1,000 to their bucket. You see that?
Yeah.
How that data crosses? That only happens once a night. It's a batch process. Okay? So
basically, what you're saying is it's gonna lead to a lot of incorrect payments and reimbursements.
Absolutely,
that's what it's all about.
And the legal risk to the pharmacy is such that a pharmacist may just say, especially your independent guys, may say, "You're going to pay me total out of pocket," and then you can submit a paper claim to your insurance company.
This is just nightmare. This is ridiculous. The bottom line here is this is just absolutely unnecessary, ridiculous. And there isn't anybody at the government level who's going to be able to make this happen, understand it, design it, oversee it, manage it. This is, I can see where a diabetic goes into diabetic shock at the counter, at the pharmacy, waiting for the prescription because all this stuff is going on. Because everybody's going to be scared to death if they don't do what the government says they have to do. That's going to be the primary objective, staying out of trouble with the government rather than servicing the patient there on the other side of the counter. And I can see it. So somebody goes into diabetic shock because they don't have their insulin, who are they going to sue? Stacy, thank you for holding on during the break. I really appreciate it. Always enlightening to hear from you, always. And thanks for your time today.